So thank you for joining us for this important discussion. This month's discussion will feature Dr. Diana Spade. Dr. Spade is a retired board-certified anesthesiologist. After practicing for 27 years in Southern Missouri, she relocated to Oregon in 2009. From 2011 to 2017, she was a volunteer for Compassion and Choices of Oregon, receiving their Volunteer of the Year award in 2015. She recently moved to Ohio and will be sharing her experiences as both a physician educator and patient advocate for those using Oregon's Death with Dignity law, the first in the US. Her presentation will also include how the law is used, who can use it, who regulates it, impediments to its use, and how other states have legalized it, as well as some information on the international use of aid in dying. So I'm going to stop sharing here. And then Diana, I think you're on mute, and you should be able to start your presentation. Here we go.
Have me now?
I can hear you. You're a little quiet, but.
Okay, can I set my volume up a little bit maybe? How's that?
Well, I just turned up my volume, so.
Oh, I turn mine back down?
You're probably good. If
I don't want to scream at people.
Yeah. If you're having trouble hearing, type something in the chat and let us know. Otherwise, we'll assume that everyone can hear fine.
Okay. All right. Well, I'll get started. I'm going to be talking about medical aid in dying, which of course, death with dignity is the choice, and end of life choice are other terms for that. A little bit of what I'm going to be talking about. Okay, my shift is not working. Oh, there we go. Okay, I'm going to be talking about terminology. We have to clear up some terminology having to do with euthanasia, the term euthanasia, medical aid in dying laws in the United States, a little bit about international medical aid in dying, and what is Oregon's Death with Dignity law, what does it entail, how to implement the law, some eligibility requirements, steps to obtain the prescription, impediments to obtaining medical aid in dying, some statistics on who uses it, what a planned death might be like, some pros and cons of having the laws, and a little bit about Ohio's end-of-life options. So about the terminology. So euthanasia, by its term, is the practice of intentionally ending a life to relieve pain and suffering. Now that can be a couple different kinds. Active, which is administering by a physician a medication with the consent. Now that's not legal anywhere in the US. So voluntary euthanasia would be like the physician providing, but the patient self-administers. That's the term medical aid in dying, and is the term that most proponents of medical aid in dying like to use. We don't use the term euthanasia, even though it's really kind of a correct term. I mean, voluntary euthanasia is medical aid in dying, but because it's such a provocative word, it is usually used only to mean active euthanasia, that administered by a physician. Passive euthanasia, and of course we don't use passive euthanasia, but it would be withdrawing life-sustaining treatment. Indirect euthanasia would be like the doctrine of double effect. And if you don't know what the doctrine of double effect is, I'll explain a little bit. I think the easiest way to explain that would be an OBGYN physician who is against abortion, but has to deal with a woman that has an ectopic pregnancy, which of course isn't viable and can kill the woman. So he would have to go ahead and do an ectopic, would excise the ectopic pregnancy, and of course the fetus would die. So that would be a double effect where you would be doing something that you didn't really want to do for the benefit of the patient. So another indirect, which is often heard of in aid in dying, would be someone giving a dying patient opioids, and in giving them that dose of opioid, it hastened their death. And you may not know for sure if it hastened the death, but there are probably circumstances where in order to take away the intractable pain, it did hasten the effect. So the effect would be, the purpose was, of course, to make the patient more comfortable, but it may hasten their death, and that would be legal. And then involuntary euthanasia, of course, that's murder, that's against the patient's will. So in my talk, and in most talks you hear from people that promote aid in dying, we use medical aid in dying. Now, you also will hear physician aid in dying or physician-assisted suicide. Physician-assisted suicide was used commonly probably when the aid in dying first started becoming popular to pass the laws in the 70s, 80s, and 90s. But because, again, suicide is such a provocative word, they began using physician aid in dying. And because a lot of physicians objected to the fact that it said physician aid in dying, but they were really not really involved except to provide a prescription. So now we've settled on medical aid in dying, and that's the most commonly used term. So is medical aid in dying considered euthanasia? No. It's both use of legal medication to end life. The difference is who administers the medication. The physician provides but does not administer. The patient decides when and where and even whether. And euthanasia requires another to administer the medication. So euthanasia is illegal in every state, and there's no real effort in the United States to legalize euthanasia. And when I talk about international laws, I'll mention, of course, that they do practice what we call euthanasia in some of those countries. So is medical aid in dying suicide? Because suicide's another provocative word. I guess by definition, which is taking of one's own life, it is suicide. But remember, a dying patient's life is already being taken. And suicide, what might be a permanent solution to a temporary problem, dying is not a temporary problem. So in comparing the two, if we have medical aid in dying with suicide, medical aid in dying, the person does have a terminal diagnosis, so they're already dying. Whereas in suicide, there is no terminal diagnosis. Medical aid in dying, the person is most often medically capable. But in suicide, oftentimes they're not mentally capable, they're mentally incapable of having a psychiatric diagnosis. Medical aid in dying, the patient wants to live, where in suicide, it's the patient wants to die. Medical aid in dying is planned, often with the family, whereas suicide is impulsive and done alone. Medical aid in dying, the death is gentle, and in suicide, the death is often violent. So in medical aid in dying, there's normal grieving process, guilt is rare, and in suicide, there's abnormal grief, and members often wonder, what if? And even the Oregon Death with Dignity law says, and when I'm talking in my discussion, I'm going to be referring to Oregon's Death and Dignity law because it was the first law. It's the basis of which every other law in the law in every other states follows, probably about 98 to 99%. And in the law, it says specifically, it shall not, for any purpose, constitute suicide, assist suicide, mercy killing, or homicide under the law. So this not only protects the person and the family, it also protects the physician. So it's not considered suicide. A little bit about the law, passing of the law. Interestingly enough, I often ask especially now that I'm in Ohio, but in 1906, Ohio was the very first state to have any legislative attempt to enact an aid in dying law. It's kind of an interesting history. It was a campaign by heiress Anna Sophia Hall. She's the daughter of the Arctic explorer Charles Francis Hall. Her mother had a long, drawn-out death from liver cancer, and she underwent a very strong letter-writing campaign to the Oregon legislature. And it did get to the legislation, but it was not passed for a 79 to 23 vote. So Ohio has a little history there. In 1967, there was a right to die bill introduced to Florida legislature. It aroused some debate, but it wasn't successful. And in 1969, voluntary euthanasia bill was introduced into the Idaho legislature, and that one failed. 1991, there was two more recent ones, or at least in the 1990s. Washington State voters rejected a ballot initiative 54-46, and in 92, California defeated a ballot measure 54-46 also. So it wasn't until 1994, the first law was passed in Oregon. It was a citizens initiative. Just to clarify, there's two ways a law can be passed. It can be passed by a citizen initiative, getting enough signatures and stuff and getting it on the ballot, or it can be passed by legislation. So in Oregon, the first law was passed in 1994. And of course, I have in parenthesis there, 1997. So even though it was first passed in 1994, it didn't start until 1997 because there was some objection. The first objection was by Right to Life organization, which put an injunction on it. So it went to court a couple of times. And finally, about the time in 1997 that it was going to go ahead and start, the Oregon legislature, which was pretty conservative at the time, initiated a ballot to rescind the bill. But the Oregon citizens didn't like that, and they rejected that bill 60-40, even more so than the original bill, support more than the original bill. And in 1997, the law did begin. And so it has been in effect now for 23 years. So as I'll talk a little bit later, there's a lot of statistics and everything that we can report on. Then subsequently, wasn't until 2008 that another state passed that bill, again by citizen initiative in Washington State. In parentheses is what that act is called. So the first couple of ones, Death with Dignity Act, Montana. Now Montana is kind of an outlier. In 2009, the Supreme Court ruled that there was the right of the terminally ill to use suicide if you want. It's a little bit more difficult to follow there because they don't have the same rules and regulations and the follow-up to really find out statistically what's happening in that state and how many people use it. Vermont was the first state in 2013 to pass the law through legislation, and it's called the Patient Choice and Control at the End of Life Act. California in 2015 passed it, Colorado in 2016, District of Columbia by a city council vote 2017, New Jersey 2019, Hawaii and Maine also 2019. So now there's a number of states. What about internationally? Now internationally, probably the Netherlands has been using aid in dying the longest, and I kind of put there in parentheses 1984. They've been using it since 1984. They really didn't have the laws in place. They just kind of allowed it in 2002. So all these countries have an aid in dying law. Only those with the little star have what you would call active euthanasia, where the medication can be provided and given by a physician. And in the other countries, in Switzerland and in Victoria, Australia, only can it be taken by the patient. It can't be given by a physician. In Switzerland, I put a little F, they allow foreigners to come to their country and utilize their law. Dignitas and Life Circle are the most common ones. People, especially from England, travel there to utilize aid in dying. It's expensive. It's somewhere from $8,000 to $12,000. You have to make several trips. You have to see several physicians. You have to have a waiting period. You have to have your remains buried there. You have to see several physicians to, decide, if you qualify, et cetera, et cetera. Interesting, a little in Belgium, also allow those 14 to 18 to use the law with their parents' permission. And of course, that's with the terminal disease. when I talked about those countries, whereas in the United States only allows those with the terminal illness, these are some of the terminology that the Swiss, Netherlands, Dutch, and the Canadians use. You have to have a disease of intractable or untreatable condition. In the Netherlands, unbearable suffering without prospects of improvement. In Canada, a reasonable foreseeable death and incurable, or a grievous and irremediable illness not remitting of remedy, cure, or repair. So this is their kind of terminology, contrast to the United States, which you have to have a terminal diagnosis. And how does the American public stand on it? The American public has consistently supported medical aid in dying by a large majority. Some of the recent polls, 72 to 74%. Also, state by state polls show there's great support. New Jersey, 68%, and most recent one in Ohio was 2018, where 69% of the people supported aid in dying. International opinion, almost all majority of citizens in most countries support aid in dying, except Poland and Russia. They're two countries where it's less than 50%. The highest support is in Belgium and France. Netherlands and Spain also are high up there with support. What about physicians? Physicians, it's increased. Medscape did an ethics report in 2014. It shows the increase for medical aid in dying, up from 46% to 54%. What are some of the medical groups positioned on medical aid in dying? A lot of medical groups kind of remain neutral. American Academy of Family Physicians, American Academy of Nephrology, American Hospice and Palliative Medicine, American Nurses Association, American Association of Social Workers, American Pharmacy Association. The American Medical Association still opposes, they're like studying it still, and the American Geriatrics Association oppose it. Those that have actually come out for support are the American Medical Women's Association, yay, women, and the American Public Health Association, and the American Medical Student Association, all supportive of aid in dying. So what exactly does the law say and do? Okay, and I'm of course using Oregon's, and like I said, all the rest of them follow through the same. It's an end-of-life option that allows terminally ill, qualified persons to legally request and obtain medication from their physician to hasten their inevitable death in a peaceful, humane, and dignified manner at a time and place of their choosing. So who implements the law? It's up to the patient and the physician to implement it. One doesn't apply to the state. It's a patient-controlled process. Physicians, institutions, and pharmacists are not mandated to participate, and patient can change his or her mind at any time. Physicians and patients who comply with the law are protected from criminal prosecution. So what are the eligibility requirements? Of course, age 18, that's pretty self-explanatory. Age 18 is considered the age of adulthood. It's where you can sign contracts. It's where you can, begin a curfew. It's when you can vote. It's when you can drink. It's when you can buy property, purchase firearms, etc. So that's a good age to have eligibility requirement for this law too. And you must be an Oregon resident. Well, there isn't an exact defined time period. Being an Oregon resident means you can have, if you have a home ownership, if you have a state voter registration, if you have a state issued ID or driver's license, or if you have a tax return. So, to move to Oregon and get your driver's license, you can have that in 2 weeks. So you're an Oregon resident. That's not going to be the limiting thing that lets you use the law. I'll talk about that later. And having a terminal well, when I say talk about it later, I might as well talk it now. So being an Oregon resident, you may have that in 2 weeks, but you still have to have the other requirements that we'll talk about. You have to have a physician. In fact, you have to have 2 physicians, and that process in itself is going to be more limiting factor than being an Oregon resident. You also have to have a terminal prognosis that's less than 6 months, determined by 2 Oregon licensed physicians, either MD or DO, not nurse practitioners. You must be able to make and communicate healthcare decisions. and you must be able to self-administer the prescription. Nobody can give you the medication. Can't be given IV, it has to be given by mouth, and you have to be able to give it yourself. So what is the process? The process is complex, and that's why when I did volunteer for Compassionate Choices, we would get contact with patients that needed assistance following through this process because it is complex. And a volunteer then would support them and give them advice on how to get through this process. Okay, the patient must make 2 oral requests to a physician. And since there's 2 physicians, I'm going to call one of them the prescribing physician and the other one the consulting, because the prescribing physician really has most of the obligations as far as the paperwork, et cetera, and writing the prescription. And the consulting physician is pretty much that. He confirms the diagnosis. So the patient makes these 2 oral requests separated by a minimum of 15 days. Now, Oregon did modify their law in January this year, where someone who has less than 30 days prognosis and is progressing rapidly, they can get that 15-day rule altered, and they don't have to follow it. And that's up to the physician to decide if they meet that criteria. The oral request must be recorded by the physician in the patient's medical records. The second oral request can be made by phone, so the person doesn't have to go back into the doctor's office again. The second, or the consulting physician, confirms the terminal diagnosis, and he also has to do paperwork. I mean, all this paperwork has to be done and sent into the state. No one but the patient can make the request. The request cannot be made by anyone else, any family members, just by the patient themselves. And then they also, once the second oral request is made, the patient must complete a written request. It's kind of a piece of paper, and it says it's a request for the medication. It's witnessed by 2 individuals, and only one of those individuals can be a relative. And then the prescription is written by the prescribing physician 48 hours after the written request. The prescribing physician's office mails or hand carries the prescription to the pharmacy. It's not faxed. It has to have the original prescription has to get to the pharmacy. Most pharmacies have to order the medication, so it takes about 2 days. The medication at the present time is a mixture for drugs. Early on, it was a barbiturate. It was either secobarbital or pentobarbital, but because those barbiturates are, well, one of them, pentobarbital, is not made in the United States anymore. It's made in Europe, and because it was used in the IV form, it was used for executions, and the European Union doesn't approve of that. They banned that drug from coming to the United States at all. So what was a really good drug to use for end of life is no longer available. The other one, secobarbital or Seconal, is a great one to use. However, it has become prohibitively expensive, as some of these other drugs that aren't used as often, and can, pills that used to be 10 cents a piece, now it may cost $1,200 to get this drug, because you need about 100 of them. So that's prohibitive. So there is a mixture of 4 drugs that's used now. Patient also gets a prescription for 2 anti-nausea medicines. Now, the health insurance does not usually cover costs of these medications. That's why it's so difficult for these real expensive ones. I mean, the mixture for the other 4 drugs are maybe $150 to $200. Now, when I say health insurance does not cover it, I will say that, and I don't know if this is true in other states, but about a year after Oregon passed the law, about 1998 or so, the legislator passed a law to allow state funds for Medicaid to be used to cover cost for the indigent. They didn't feel like it was fair that if you wanted to use the law but couldn't afford the drugs that, or seeing the physicians even, that you should prohibit it. So Medicaid will cover the cost in Oregon. Family member then picks up the medication from the pharmacy, but it can be held at the pharmacy till the time of use. And I think, especially when Seconal got so expensive, I mean, it kind of was a build-up time. A lot of people waited till the end to get that prescription filled. Because when we talk about the statistics, not everyone that uses the law or gets the prescription ends up using it. So the death certificate at the end will say death due to the underlying disease, like cancer of the lungs or cancer of the liver, whatever they were dying of, and that the death occurred naturally. It does not state that they used aid in dying. And of course, since it's not by law considered suicide, life insurance benefits are not affected. So what's the physician's responsibility in this? So physician's responsibility is determine if the patient has a terminal illness, is capable, made the request voluntarily, and is the state resident. If indicated, there's a psychiatric exam. Very seldom is a psychiatric exam required. Now, the groups that oppose aid in dying said not enough psychiatric evaluations are undertaken, that the only reason that people undergo and use aid in dying is because they're depressed. I can imagine just about anybody that has a terminal diagnosis is probably a little depressed, but to say that I think it kind of diminishes them to say that the only reason they're using it is because they're depressed. So maybe 2 cases out of the year, there'll be a psychiatric evaluation, but the physician does have the right to ask for that. The physician must also inform the patient of alternatives such as palliative care, hospice, and pain management. Request that the patient notify the next of kin, but the patient does not have to notify the next of kin if he doesn't want to. It's not required by law. Offer the patient opportunity to rescind the request and willing to refer to a consulting physician, and also willing to sign the Oregon Department of Health forms. So what are the impediments to patients implementing the law? The lack of knowledge about end-of-life choices. They just may not know about the law. Resources, finances, or their medical insurance doesn't pay for it, and they feel like even maybe a couple $100 for medication is too high. And also, one of the big problems is lack of physician participation. I can't speak for the other states, but I know even in Oregon, although the law had been there, even when I volunteered, it had already been there for 15 years, there was still certain areas where really there was low physicians' participation. And what it was required was just continued education, continuing educating the physicians about how to access the law, because a lot of them think it's going to be just too timely, too much trouble. Also, another impediment is failure to initiate the process in a timely manner. So if you have a terminal diagnosis and you can see there are some rules and regulations, they don't know where to go, it might be too late by the time they get in the process. Loss of competency could occur, and then the ability to self-administer the medication. This would be especially in patients that have a neuromuscular disorder. They lose their ability to hold a cup and take a drink. They wouldn't be able to use the law. Now, when it's self-administered, your patient can have a feeding tube in, because the medication can be poured into the feeding tube, but they would have to be able to pour it in. They couldn't have someone else do it for them. Some impediments to the physicians participating: lacks understanding of the process. Personal beliefs is a big one. Fears angry family. Patient needs timely appointments. Too much paperwork. Group decision not to participate. Some physicians, if you're in a group practice, they can vote to have a group decision, and the individual physician may want to, but the group has decided as a group not to participate. And then, of course, any Catholic affiliation prevents participation. So in this day and age where most physicians are part of a hospital practice, any Catholic affiliation, if that physician is working for a Catholic hospital, they are automatically not allowed to write the prescription. So what are the main end-of-life concerns that people request the law? And it's, interestingly, it's not pain. Pain is not the most concern. The loss of autonomy, 92% almost unable to engage in enjoyable activities, 90%, loss of dignity, 66% say that's a problem, being a burden on your family and friends or caregivers, losing control of bodily functions, inadequate pain and pain control is some concern, financial concerns over the treatment. So opponents of the law say, well, look, it's not even pain that these people are suffering, so why are they allowed to lose the law? But we're realizing that pain is not just physical pain, but existential pain. So people have decided that their, desire or the way they live their life is not enjoyable, is important to them. So loss of autonomy is just as important to them as pain in continuing their life, having pain. So what are some statistics? The Oregon the Public Health Division has an annual report every year about the statistics of the Oregon law, and it just came out in March of this year for 2019, and there was 290 death with dignity prescriptions written and 188 deaths. And so only 64% ended up using the prescription. And this has been throughout the since 1997. About 64 to 67% every year. As you can see, the year before it was 67%. But if you look at the statistics for the last 17 years, it's pretty consistent that about 2/3 of them use it, and the rest just had it there in case they needed it. They had the peace of mind of knowing it was available. Since 1997, as you can see, it's about 66%. There's been a total of 1,657 deaths, which is a lot of deaths for 17 years. So here, and this is kind of a bad slide, but this kind of just shows you the deaths per year and how it's increased since 1998. So it's just been a gradual increase. There was a big jump about 2014 and 2015, and that was about the time of Brittany Maynard. I don't know if you remember hearing the news. She was a young woman from California that was dying of brain cancer, aggressive form, and California at that time didn't have the law, and this is a case, this is very unusual, and I think it's the only case I know of where someone actually moved to the state to utilize the law. She moved to the state, established her residency, and then utilized the law in Oregon. Now, I talked about being the limiting thing is that she did have a physician friend in Portland who helped her find physicians that would, the physician that would see her and clarify that her diagnosis was in fact terminal. So not everybody would be so lucky as to be able to find physicians, especially that quickly. I mean, you have a terminal diagnosis, less than 6 months, to find a physician might be a little bit difficult. But anyway, so all the publicity from that kind of jumped it up through those years. So if you look how many deaths are used from this in Oregon, in 2017, which is the last time I could find all death statistics, there were 36,000 deaths in Oregon, and 168 of them were death with dignity, which is 45 deaths per 10,000, which is pretty low use. So who uses the law? And this on this slide, the 2019 statistics is in black, and in red is what the average statistics for the last 23 years. So, and you can see in almost every circumstance it stayed the same. The median age is 74 years. Last year, 72 years average. It's a little bit more male than female, but not that much. Last year was maybe a little bit more than I would say in 2000. When 2017 did it, it was actually 51 female. So, varies a little bit. It's almost predominantly Caucasian, 96%. But remember, Oregon is about 86% white anyway, but it is predominantly Caucasians that use the law. And it's well-educated people. 53% have at least a baccalaureate, and that's been consistently. Most have a cancer diagnosis. That is decreasing somewhat. Early on, it was up into 78% cancer diagnosis. What's increasing is there are more people with neurological diseases utilizing the law. And of course, that's a little bit more difficult to give a 6-month diagnosis to than like cancer. And 94% died at home, which is high for a lot of states, and for even people that die normally. So, I mean, if you looked at all the people that might have died, the percent that died at home would not be as high as those that use the law. And that's most people's preference, is to die at home. High use of hospice, 89, 90% were in hospice. And insured, 98% were insured, which a large majority of those had Medicare and Medicaid. Now, the statistics doesn't separate those out. They throw those together, and that's what they are. They are 69% have either Medicare or Medicaid, but the statistics are not separated. So Oregon is a leader in end-of-life care. And some say that actually Oregon's Death with Dignity law actually made Oregon better in their end-of-life care. High percentage of deaths at home, a high rate of hospital referral and use, high opioid prescribing rates per capita. And we're talking about terminal. It's maybe not a good thing to have a high opioid use, but it's a high opioid prescription rate for your terminally ill is an indication that the terminally ill are getting adequate pain relief. Prior to instigating this law, Oregon in the early 90s had one of the lowest prescribing rates. So maybe there were a lot of people in Oregon that were dying with pain, but with the law, hospice and other people became more concerned that people were utilized the law because they were uncomfortable. So there was a big step up for end-of-life care. Statewide use of a pulse system, which is, I don't know if you know what that is, that's physician orders for life-sustaining treatment for, if you understand that your living wills that you have that designate what healthcare you want toward the end of life does not work in emergency situations. If an EMT comes to your house or whatever, that don't mean anything. You can still be resuscitated. You can still have a breathing tube put in. So the pulse is an actual physician's order. And Oregon was one of the first areas to have a pulse. They have a very computerized pulse system. You carry around a card. So if you have a faint or whatever, if you don't want, you may be elderly, frail, and you don't want to be resuscitated, then you can have that card and pull it right out and say, I don't want to be resuscitated, or I don't want to have a breathing tube in. Ohio does not have that. Only thing Ohio has is a do not resuscitate, which is, I believe, only used in the hospital, and that's strictly only for not putting in, not resuscitating. It's not for, I don't want to take water, or I don't want to have a feeding tube and that kind of stuff. They've had a lot of desire to try to get a pulse, or some call it MOLS, begins with an M, medical orders, but that hasn't been able to pass legislature. There's a very, very strong right to life movement in Ohio, which I'll talk about when I talk about the work that the End of Life group have tried to do in Ohio. And so they even object to most impulsed orders. I don't understand that, of course. You probably don't either. High quality palliative care training for physicians and healthcare workers in Oregon. So a volunteer role in Oregon in aid in dying. For those who wish to use aid in dying, they can call Compassionate Choices or End of Life Options. Those are organizations in Oregon that help, and they'll determine your eligibility, and they'll also, like I said, guide you through the process, support and guide you. And if desired, you can have a volunteer be present at the planned death, being there to help the family, or maybe even mix the medicines if the family members don't want to mix those medicines. But if one needs a participating physician, like the physician, this person wants to use a law and their physician won't, then the Compassionate Choices End of Life medical director will try to help locate one. And that's not a guarantee. may have to refer the patient to different towns. And while I was in Oregon volunteer, I kind of did both. I trained as a guide and support through the process, and then later on, and then was even present at some planned deaths. And then later, the last year or two, I helped as a medical director in finding participating physicians. So I kind of did a little of both. So what is exactly a planned death? So once someone has gone through the process and they've gotten their medication, they can pick a day or a time or a location that they desire. And this is like, you know, differs for every patient. I've had people that went and just put a lounge chair out in their garden, or if they lived out in the country. One lady wanted to be by her horses and take the medication. And within 15, 20 minutes, they've passed. Some people have a party, a get-together, and they invite all their friends and they say goodbye. And then they retreat to their bedroom, whatever, and take their medication. If so, I mentioned before, volunteer can be present if the patient desires. Hospice may or may not be able to be present. Like I said, most of these people are in hospice. If they're hospice, most hospices are associated with a hospital. And if the hospice is a Catholic hospice, they probably won't let them be present. They'll probably leave while the medication is taken and then come back later. Other hospices will stay. In fact, even as the 4 or 5 years I was involved, hospice participation, I want to say acceptance grew. I think that the hospice nurses and social workers saw what a benefit was to certain patients. And at the beginning of my experience, sometimes every hospice nurse or whatever would leave and then come back. And then later they stayed and wanted to be with their client, and they supported their decision. The hospice, their whatever charter says they will do nothing to hasten or delay death. So I think they thought if they were there, that in some way they were participating in hastening. But no, they weren't. It's the patient that was making that decision. There wasn't anything that the hospice was doing to hasten or delay. It was the patient. So yeah, they want the patient to have food for 4 to 6 hours. Clear non-fatty liquids are okay, but any fat in the diet can help delay the absorption of the medication. Mortuary staff like to be known if this was going to be a planned death prior to that. The patient is given an anti-nausea medication, and the hospice staff and everything will handle everything after that. So I thought we'd discuss a little bit about, since we have a lot of states that don't have the law, is what are the arguments in favor of and against medical aid in dying. The main one for, of course, is respect for autonomy. So medical ethics today places huge emphasis on the principles of respect for a patient's autonomy. It's the patient who now makes the final decision as to what medical treatments they want. So there's a significant respect for the rights of individuals to make their own decisions about their own life. Competent adults should have the right to choose the timing of their inevitable death. Justice is another thing. We should treat all cases alike. Terminally ill adults have the right to refuse treatment that will prolong life. Some can do this, some can't. So assisted death may be the only option to hasten one's death and should be allowed. Compassion. Suffering means more than just pain. We talked about existential pain, and existential pain is real pain. The loss of independence, the loss of the sense of self, functional capacity loss that jeopardizes their dignity. Medical aid in dying is a compassionate response to unremitting suffering that allows the patient to take control of his end of life. So honesty and transparency. Some acknowledge that assisted death already occurs, albeit in secret. So in New England Journal of Medicine did a 1998 anonymous survey, and it said 3% of all US physicians had written a prescription for life-ending medication. And 5% of them said they had given a patient a lethal injection. So this brings everything out into the open. So what are some arguments against medical aid in dying? Of course, the sanctity of life is the main one that religious people object. There are religious traditions that uphold the sanctity of human life above autonomy. They view medical aid in dying as morally wrong, considered to diminish the sanctity of life. But remember, this is an individual belief. It's personal. No one is forced to participate, either use or prescribe. And so the question should be asked, does your religious belief negate my autonomy? So passive versus active. So some think that there's a difference between passively letting die and actively writing a prescription. So they'll accept withdrawing, withholding life-prolonged treatments, do not resuscitate order, or the doctrine of double effect, or discontinue ventilators, but they disagree with the active. But is there really a difference? So ultimately, all of these will have hastened death. Some argue about potential for abuse. So vulnerable populations will be pushed into assisted death. It'll be minorities, it'll be the uneducated, it'll be disabled. But there's no evidence after that, after 22 years of use. And I'll bring this slide up again to show you who uses it. And it's well-educated. It's not females more than males. It's not people that are uninsured. So the disadvantaged are not being disproportionately affected. So professional integrity, physicians object and say it's against their professional integrity to use, and they often use the Hippocratic Oath. I will not administer poison to anyone where asked. And remember that some argue that the Hippocratic Oath was at a time, or Hippocrates was at a time where there was a lot of political assassinations. And what he may have meant is he didn't want those to be, administering poison just for a political assassination attempt or whatever. Okay, so just a little bit about the Hippocratic Oath. First of all, I don't think there's any there's no medical school in the United States in this day and age that even use the Hippocratic Oath, that say the Hippocratic Oath anymore. Either medical students write their own, or they use modifications like the Oath of Geneva, which came out of the Geneva Convention, which cites a lot of the same things the Hippocratic Oath does, but without some of the things I'm going to show you right here, like the first. It says, I swear by Apollo, the physician, Aeschylus, and Hygeia, and Pangaea, and all the gods and goddesses. So I don't think most physicians are going to want to make oaths to multiple gods. Second of all, it says, and to regard his offspring as equal to my brothers in male lineage and teach them this art, which means that only males at that time were allowed to be physicians. So we don't allow that anymore either. And teach them this art without fee, stated in there, which means they should pass down this art and not charge for teaching. And most importantly, I will not use the knife, not even on sufferers from stone, which means that you cannot practice surgery. So you can't just pick one little segment about the Hippocratic Oath and say, well, we can't use it because it says you should make up a poison, when obviously the oath is considerably out of date. So like I said, hardly anybody uses the oath. They either use the Declaration of Geneva, or there's another oath by Louis Lasagna, which kind of promotes a little bit more preventive health care. And like I said, more than half the medical school classes write their own. Most importantly, Hippocrates said, first, no harm. So prolonging dying itself may be harmful. Assisted death may be most beneficial approach under the circumstances. And it is the patient, and only the patient, who can judge whether death is harmful or a good to be sought. Another objection is erosion of trust in the physicians. However, if you look, in 1996, 75% of Americans had trust in their physicians. Today, only 34%. So if you look at the countries that have a high of probably 10 to 20 times higher use of aid in dying, both passive and active euthanasia, Netherlands and Belgium have 88% and a 91% trust in their physicians. So it did not erode their trust in the physicians to have an aid in dying law. And what about the fallibility of the medical profession? What about problems with diagnosis and prognosis? What if the diagnosis is wrong? The law does require 2 physicians to certify the diagnosis. And what if the prognosis is wrong? But most studies show that physicians are more often to overestimate than underestimate a prognosis. Well, maybe these patients are just not getting enough palliative care, and that's the reason they want to use the law. But in Oregon, 90% who use the law were enrolled in hospice. Hospice enrollment is considered the best practice for palliative care. And the rate of use of medical aid in dying has been described as very low by researchers, suggesting that the quality of hospice care is high in Oregon. So, those that support medical aid in dying believe that terminally ill adults, being fully informed of their prognosis and all options concerning end-of-life choices, have the ability, wisdom, and right to decide their fate. Aid in dying does not cause more people to die, but it does allow less people to suffer. So just a little bit about Ohio end-of-life options. Does have a nonprofit organization that advocates for patient-directed end-of-life care, advocates for medical aid in dying legislation. Mission statement says to raise awareness, provide education, advocate for medical aid in dying in Ohio, but our efforts go beyond passing a law. Coalitions or a building will put in place to provide support for those who choose to participate in the law in the future, patients and healthcare professions alike. So how's things working out for the law in Ohio? And in 2018, the Senate Bill 249, Ohio Aid in Dying Act, did get a hearing in the Health and Human Service Medicaid Committee. The bill did not advance, even though I mentioned supported by Ohioans 69 to about 69% favoring. It was sponsored by Charlotta Traveris and co-sponsor Joshua Savani and Kenny Yuko. Charlotta term limited out. So presently the bill needs new sponsors. So hopefully in 2020 or 2021, maybe we'll find some new sponsors for the bill, but that's where it rests right now. So if you're interested in more information or resources, Ohio End of Life Options web page is here. Death with Dignity National Center is a good resource for information about aid in dying throughout the United States, as well as compassionate choices. And now if there's any questions, I'm here.